Hello, everyone. Welcome to the Teaching Points recap session. I am Manuswini, and I'm really excited to be here facilitating this session. We have Dr. Hans, Shiva, and Mohammed presenting today. Fantastic team members, and eagerly looking forward to learn from all of you. We first have Shiva going. Shiva, do you want to introduce yourself and present?
Yeah, giving us this opportunity, Manaswini. Yeah, to do my first teaching point recap. Uh, I'm an IMG from India, currently in Buffalo, working as a research assistant here. So looking forward for the discussion.
Awesome. So, do you want to start with your teaching points?
Oh, yeah, sure. I thought we are doing okay. Go on. Sure. Just can you accept my request so that I can share the screen? Yeah, perfect. Got it. Can all of you see my? Okay. So uh, talk about the case by Shreya on February, Ravi and Ketan. So in this case, 44-year-old male with a history of diabetes and orthostatic hypertension was presented with dizziness. And patient was recently started on a sulfonylurea, and later we found out that she has low hemoglobin, low hapto, and high retic count. And the diagnosis was a G6PD deficiency triggered by sulfonylurea exposure. So in this patient, actually, the first question is like, can the patient's orthos be completely explained by a diabetes? So that is a question because usually we associate like diabetes autonomic neuropathy causing orthostatic hypotension. But in general, what is orthostatic hypotension? To define that, the patient needs to have a systolic of the drop of systolic blood pressure greater than 20 and diastolic greater than 10 mm within 3 minutes of standing. How do you measure that? We need to rest the patient for 5 minutes, and then we have to take supine readings as well as standing like 1 to 3 minutes. And usually orthostatic hypotension in terms of base rate, more common causes is like non-neurogenic causes, particularly like volume. Uh, so how do test that we can do is del delta SPP. So here we see like a drop in uh, activate its baroreceptor reflex, and it will release up norepinephrine, and it will increase the blood pressure if the blood vessels itself has enough volume. So that is why we need to see increase in heart rate when we stand up. So this ratio can easily help us find out whether it is neurogenic bucket or non-neurogenic bucket. It's not useful when because the tachycardia complication itself. In our case, we here the most common non-neurogenic causes are medications in elderly. So we have to review the medications and everything like and dehydration, like volume status, whether the patient is on any diuretic that we have to make sure. And the thyroid issue, adrenal insufficiency, these are the most common non-neurogenic causes. In our patient case, we found out and the other neurogenic causes are like neurogenic can be divided into central and peripheral. So the central causes are basically in that baroreceptor reflex. It has to central nucleus tractus solitarius or else the central lesions, which are most commonly seen in Parkinsonism, MSA, these kind of things. And the peripheral things, it is basically diabetic neuropathy or pure autonomic failure. With this, we can plasma norepinephrine level, which will help us to see whether it is preganglionic or postganglionic. In our case, we found out that the has a hemoglobin A1C of 6, but the patient's iron panel is normal So we have to make sure whether it is true HbA1c or not. So usually deficiency anemia to have falsely because the RBC is longer. So uh, with your with other so that you'll HbA1c control. So in hemolytic anemia, you will have falsely low HbA1c, which happened in our case because the patient is having hemolysis going on, and the HbA1c is 6, which is falsely low. So in our case, we have seen that the patient came with a hypotension. Can hemolytic anemia cause hypotension? And the answer is yes. And in our case, we have seen that. Usually, we always associate like when we see anemia, like acute anemia can cause hypotension, whereas chronic anemia doesn't cause because the heart, we have compensations which will compensate for the low blood pressure and it will be normal. So usually, whenever you see hemolysis, you need to think whether it is intra autoimmune or non-autoimmune. Done negative, which does immune mediated, and in hemolysis, intra versus extra. And here, clinically, you can think of clinically you can ask the patient, is you if it is red in color, why is it important? Intravascular hemolysis is acute and it is an emergency. Hemoglobin is not good. Renal damage and end or you have to go. So how do you differentiate? Clinically, you can globinuria, all these things. Values, you can see like LDH is usually vascular, next and let's go to immune mediated hemolysis. Here, once you get the Coombs test and confirm that is immune mediated, you need to know whether it is uh, IgG mediated or IgM, like basically warm autoimmune hemolytic anemia or cold autoimmune hemolytic anemia. So we have to do monospecific DAT test. If we see IgG immunoglobulins, we will go with warm hemolytic anemia. If you see IgM or C3D plus, you think of cold autoimmune hemolytic anemia. And one way we can remember this is usually I associate like IgM as a man in a suit. Usually it is cold, so the man will be wearing a suit to cover it up. So you can associate like that. IgM is cold autoimmune hemolytic anemia. And there is a little bit of complexity in this test interpretation. So this is out of the scope for this discussion. But later on, once we go forward and rule out all the immune-mediated hemolytic anemia, then we have to go to the non-autoimmune, non-immune hemolytic anemia. So which is our case here. Yeah. Here, the most important thing is we need to order a smear and we have to rule out the most morbid cause that is MAHA or TMA physiology because as I said, it is an acute event and the morbidity is high. So for that, we have to order ADAM-TS13 or something, ADAM-TS13 and find out whether the patient has TTP or something like that. And the other differentials, G6PD, sickle cell disease. Basically here, as Dr. Avi mentioned, RBC, we can think of membrane hemoglobin, and enzymes. So membrane defects are basically hereditary spherocytosis, order osmotic even in the smear itself, we can see the spherocytes. But it is not specific because spherocytes can be seen in other conditions as well. And when you go to the hemoglobin part, you can think of sickle cell thalassemia. In our case, we have done HP electrophoresis and we ruled out those conditions. And then there comes the enzymes like G6PD deficiency and pyruvate kinase deficiency. So we found out that the patient has a G6PD deficiency in our case, which was triggered by oxidative stress bisulfonylureas, which is glipizide, which was initiated 3 days prior. And these are the common causes which can cause non-immune hemolytic anemia like MAHA, G6PD, sickle cell, and even the parasites that we can rule out like malaria, babesia through peripheral smear. So smear is very important in non-immune hemolytic anemia. And Yeah, that's all I have. And the other one, one more cause is paroxysmal nocturnal hemoglobinuria, which was ruled out in our case by negative flow cytometry for CD55 and 59. That's all I have. Thank you so much.
Thank you so much, Shiva. That was so detail oriented and superb. Thank you so much for bringing in your presentation and presenting it so well. Now we're on to the next presenter, Dr. Hans. Dr. Hans, would you like to introduce yourself? And actually, he needs no introduction in the space of teaching points recap. We all get to learn from Dr. Hans, which is excellent. So, would you like to go, next, Dr. Hans?
Yes, I'll be next, and I hope, fingers crossed, my internet will be fine. I hope it's okay if I turned off my video during the presentation to make sure that it's fluent, at least technically. Okay, then I'll share my screen. Just a second. Share. Just a moment. I thought I had it up. Just one moment. It's a PDF file. Yeah, there it is. Thank you for bearing with me. And my case is from February 12, and the case presenter was Riku, and the discussants were Rabi and Julia. And our patient was a 24-year-old female, and she presented with fever, painful swelling, and bilateral ankle swelling. So when we have these symptoms, I usually go step by step. That is, I look at the fever, the difficulty swallowing, and the bilateral ankle swelling separate, and then at a later point see whether there is an intersection between all of them. For fever, we have our well-known IMAID, which is an infection, inflammation. It can be malignancy or metabolic derangement, but patient could have taken drugs that increase the body temperature, or it could be an endocrine problem like a thyroid storm. The difficulty swallowing, it's a sore throat or pharyngitis, points towards inflammation in the throat. And there we have some red flags, such as maybe a space-occupying mass, or is it a thyroid disorder where the thyroid presses against the trachea and the pharynx? Then the bilateral ankle swelling could just be something separate, like the patient sprained or strained her ankle, or is it related to the above symptoms? Now, before we go into all of those, because of the difficulty swallowing, that is a red flag, and we are to rule out life-threatening processes. And here I have a very nice video from Dr. Jack Penner about sore throat and pharyngitis. And when we do our physical exam, we have certain signs and symptoms that indicate seriousness, such as deep space infections that we have here. And the question is this an unilateral swelling of the throat? Is it the entire throat, or does the patient show trismus, not able to open the mouth very well, or is the patient altogether sick? Then when we do a physical exam and listen with our stethoscope, then we listen to the voice. Is it like a hot potato voice that he made, which indicates something serious deeper in the pharynx? Is the patient drooling, stridor to be heard, which is very serious because it affects breathing? Or is the patient in a tripod position? And all of these red flag symptoms can be associated with certain infections in the different layers of the throat. The submandibular space is the green one. And swelling and abscess in this space is known as Ludwig's angina and can be secondary to an infection in the mouth, such as a tooth infection. Now, if that infection reaches the next layer, which is the retropharyngeal space, then an abscess there with inflammation can cause a thrombosis of the jugular vein, which then in turn is known as Lemierre syndrome and is very serious. If the infection gets even deeper into the red space, which is the danger space, that is a highway to the mediastinum, and that would be very serious. And rarely, if ever, it reaches the paravertebral space. Now, if we can rule out all of this, we have time. So in general, our patient might not be in danger of anything serious. Then we have a run-of-the-mill pharyngitis. That is, we rule out alarm symptoms. And then we have the center of gravity, our throat. And then if we have a focal infection, we do some testing. If the viral panel is negative, then we can think of bacteria and consider antibiotics. If we do have a bacterial infection, then we just wait it out with some anti-inflammatories. In general, however, especially with our 24-year-old lady, we have to make sure that we can rule out all sexually transmitted diseases. So it would be syphilis, and there we already have a connection, fever, inflammation, and joint pain. Or it is gonorrhea, and gonorrhea, same. It can affect the joints, cause a rash even, and then chlamydia. So now to the history of present illness. The patient says that 4 days before her presentation to the ED, she developed painful swallowing with white patches on her throat, and 2 days later she had left ankle swelling, and then right ankle swelling. And for mobility today in the ED, she even needs a wheelchair. So it seems pretty serious. She also noticed a spot-like rash on both ankles, and she admits to myalgia, muscle pain. Her vitals and the physical exam. Vitals look very normal. She's tachycardic, but otherwise, probably from the pain and the distress she's in, she seems to be fine. She has an erythematous pharynx with swelling, non-painful palpable lymph nodes. So this could be just a run-of-the-mill pharyngitis. The extremities, however, are swollen. They are warm, and we have tenderness and limited range of motion. And the skin shows a non-blanching rash on the lower extremities. Heart and lung were fine, no wheezing, no other problems. The rash is shown here, and it looks a little bit salmon, velvety colored on the picture. So now we have a program presentation that tells us we have a sore throat with fever, we have a skin rash and ankle swelling. And the differential for this one is overwhelming. We could have Neisseria gonorrhoeae with arthritis, septic arthritis, after a sore throat. We could have a rheumatic fever that she incurred from an earlier or even this strep throat. But then our rash would be more erythema marginatum, and it looks different from what we see here. Then we could have adult onset Still disease, which is an autoinflammatory disease. This involves the complement system rather than the adaptive system in other diseases like lupus. And there we have a salmon-colored rash, but we also have off and on fever, and the disease, the diagnosis can be very elusive. HIV, we need to rule it out, but it would actually cause a rash in the upper body as well, not just the lower extremities. Viral exanthemes like mononucleosis are very likely in this patient because we see it in this patient population. A spondyloarthropathy and reactive arthritis are possibilities secondary to an infection. And then we have, as another possibility, an IgA vasculitis, which causes a Henoch-Schönlein rash, and it's a palpable purpura. It's raised, it's reddish, and it's non-blanching. So in the past, we had several cases of pharyngitis and sore throat. May 20, we had Lemierre disease, and that patient really presented with a focal swelling in the throat. We had pharyngitis in October 1st, 21, and that was a thyroid storm secondary to a strep throat, and that was quite surprising. I never knew that this can happen, and I think it was Tiago Mendes, our endocrinologist, discussing the case. Then we have a sore throat in a 10-year-old boy, and he developed painful knees, and that was an osteomyelitis proven with blood culture. And of course, a tab of the joint. And then we had a rash on the buttocks in May 27, 22, and that was something in a middle-aged person. I think she was female and was Listeria meningitis. And then we had fever, sore throat, which is very elusive in a patient with a maculopapular rash in April 21, and that was adult Still's disease. So we've seen basically all cases on VMR. For the present patient, the hospital course she was admitted included a throat swab, and it was positive for S. aureus. But here we have to be very careful. It can be positive in the absence of an infection because S. aureus lives on our skin. The biopsy of the rash was done, and the empiric treatment for N. gonorrhoeae was right away initiated to rule out a gonococcal infection. Then tests for all the sexually transmitted diseases were negative, and the patient improved with ceftriaxone, and the result of the biopsy was very amazing. It was an IgA deposition in her vasculature. So the diagnosis in the end was a leukocytoclastic vasculitis with IgA deposition in a young person, not the kidneys involved. And this has an excellent prognosis. It even goes away on its own. But it means that each time the patient gets a sore throat, she might develop this complication. So how is IgA vasculitis presented clinically? And there we have a petechial rash. That's what our patient had. But on the legs and buttocks, and the prime example is Henoch-Schönlein rash that we have seen in our undergraduate. Then we have arthralgia arthritis, can happen. Gastrointestinal symptoms of IgA is not very unusual with bloody stools. And then we have renal involvement in adults, and that has a fairly bad prognosis. And the general features are basically low-grade fever and headache. So what is the pathology of IgA vasculitis? And that goes back to our IgA immunoglobulins, of which we have two kinds, isoforms. One is IgA1 and IgA2, and the IgA1 exhibits a hinge region, that is where the two Ys are coming together, which is extended and can be glycosylated. Now, in IgA nephritis and vascular nephritis, we have seen that the IgA hinge region is galactose deficient. And this means that underlying carbohydrates are now being exposed, which are normally not exposed to the immune system. And that can give rise to anti-IgA1 antibodies. And these anti-IgA1 antibodies, in the next step, can then cause IgA immune complexes in the body, which are so big that they are no longer metabolized in the liver. They accumulate and they are deposited in the glomeruli. And that would be IgA nephritis or IgA vascular nephritis. So we have those complexes now accumulating in the kidney. They are attached to the transferrin receptor on mesangial cells, and these cells in turn are then stimulated to produce even more of those receptors, and that is a cascade which in the end activates the complement system and causes renal decline or renal failure. By contrast, IgA vasculitis without kidney involvement, there we have something like antimicrobial mimicry, where IgA antibodies now, after an infection, bind to endothelial cells. And this process is enhanced in the presence of inflammation. These endothelial cells, after the IgA1 are attached, are activated. They secrete interleukin 8, and that attracts neutrophils. And of course, these neutrophils then interact with the constant part of the antibody. They are then in turn activated, and then they release a leukotriene B4, which is a potent neutrophil attractant. So even more neutrophils come into play, and these neutrophils, and they are really active, they secrete reactive oxygen substances. They undergo what they usually do when they see an infection, a lytic cell death. They release their interior of the cell and they encapsulate or entrap foreign intruders, but in this case it's endothelial cells, which they shouldn't do. And here is just a definition of netosis, which means neutrophil-lytic cell death. These guys are kamikaze fighters, which release chromatin and antimicrobial granules to destroy foreign intruders. And these are my literatures that I consulted. And I hope my internet was fine. And I want to thank you very much for the opportunity to hold this presentation.
Dr. Hans, that was unreal. What a fascinating presentation, and so much to learn from it, from the differentials to pathophysiology. You took us all home, and it was amazing. And everyone on the chat is in all praises for you, Dr. Hans. Now, after two amazing presentations, now we're moving on to the third. We have Mohammed. Dr. Mohammed, do you want to introduce yourself and then present?
Hello, everyone. I'm Mohammed, a medical graduate from Iraq. And unlike Hans, I have non-inflammatory case to present today. So let's start with sharing my screen. Do you see a full screen right now? So this is VMR is the 25th of February 2026, a case presented by Dr. Youssef and discussed by Brafrez and Dr. Sharmin. So this is a 61-year-old female has a history of hypertension, dyslipidemia, and present with acute substernal chest pain. So with that history, we have famous 4+2+2 schema, in CPS, that we want to prioritize life-threatening causes, including but not restricting to acute coronary syndrome, pulmonary embolism, and also aortic dissection, along with tamponade and intact supracardiomyopathy. So this patient who has a previous cardiovascular risk factors make us really prioritize ACS, PE. So we send the baseline test for these conditions. So we sent for EKG, troponin, D-dimer, and chest X-ray. So this patient ECG shown here, that is notable for ST elevation in lead 2, lead 3, and AVF, as you see here, as well as in lead V6. So in ST elevation could mean many things, but when it is consecutive ST elevations and associated with ST depressions, aka reciprocal changes. In this case, reciprocal changes was not very obvious in this ECG. And also in 2-3 AVF ST elevation, we're looking for ST depression in AVL and lead 1. So we sent also for troponin, that was 14,000, and that was very high. So ST elevation with reciprocal changes plus troponin that's high really screams obstructive myocardial infarction. So the patient went to coronary angiography. There is no atherosclerotic rupture, there's no thrombosis found. Instead, they found coronary artery dissection involving the left ventricular descending artery. Clinically, the patient was also by echo shown that ejection fraction is decreased. So based on these findings, the patient was diagnosed with spontaneous coronary artery dissection or SCAD. So SCAD, the patient have further investigations and by CT angiogram showing that there is not only the coronaries involved, but the carotids, the renal vessels are also involved. And based on the CT angiogram findings, patient was diagnosed with underlying fibromuscular dysplasia. So let's talk a little bit about SCAD and FMD, fibromuscular dysplasia. So both of these conditions SCAD, let's start with the SCAD, is a non-inflammatory, non-atherosclerotic, non-traumatic dissection of the coronary vessels leading to intramural hematoma that could obstruct the vessel. It occurs in younger patients and in patients with no cardiovascular risk factors, although this patient have cardiovascular risk factors. It is commonly associated with pregnancy, it can occur peripartum, associated with fibromuscular dysplasia and connective tissue disease. Diagnosis, as we see in this case, we cannot make a distinction based on ECG, for example. It's similar to obstructive myocardial infarction. So the diagnosis is on coronary angiography features. And theoretically, the diagnosis could be an even CT coronary angiogram. And the treatment is similar to patients with atherosclerotic acute coronary syndrome. So I have a very small diagram here. Imagine if this was a cross-section of the coronary vessel. What are the pathophysiology of SCAD? So it could be either an intimal tear, and this intimal tear causing a blood to sweep into the vessel wall, called inside-out approach, or this orange circle is a vasa vasorum, and this vasa vasorum could rupture, causing intramural hemorrhage. Both of them, this is outside-in approach. So both of these, let's say, pathways result in a common pathway, which is intramural hematoma that could expand and block the lumen. So this patient's underlying disease was fibromuscular dysplasia. It's also defined as non-inflammatory, non-atherosclerotic, systemic vascular disease. It affects the musculature part of the blood vessels, medium and small size vessels, causing aneurysms, causing dissections, and causing stenosis. We commonly hear about fibromuscular dysplasia in the context of renovascular cause of hypertension, and also it can cause renal infarction, and also can cause CVA. In patients with fibromuscular dysplasia, they have 5 to 10 times higher risk of SCAD. It's commonly diagnosed below the age of 50, and it is female predominant disease. And in some US-based studies, the epidemiology is very high. The female to male ratio is 9:1. Diagnosis as in SCAD is imaging. The cornerstone is CT angiography. We can see a string of beads appearance. So this image here, CT from Radiopedia, we can see that this is the aorta here, and the right and left renal arteries, and we can see a string of beads here. Fibromuscular dysplasia has a further classification. It is more a pathological classification than a clinical one. It's based on which part of the vessel wall is affected by the fibrosis. Is it the intima, is it the media, or is it the adventitia? And the most common is the medial fibromuscular dysplasia, causing string of beads. And in intimal-based fibromuscular dysplasia, the most finding we see on CT is a stenosis rather than a string of beads. So the therapeutic goals of fibromuscular dysplasia is according to the vessel affected. So renal vascular disease, we have to control hypertension, and also we have to control cardiovascular risk factors. In selected patients, there is also revascularization. So take-home points of this case, that when we have a chest pain in CPS, we think in reflex of 4+2+2, highlighting ACS, pulmonary embolism, and aortic dissection. When we see a ST elevation, it could be something like structural to the heart muscle, could be something electrical, and also could be something like ischemia. So we highlight obstructive myocardial infarction, vasospasm, coronary artery dissection, and demand ischemia, as well as PE, massive PE, and myopericarditis. The presence of reciprocal changes make us think about coronary pathologies. SCAD management is similar to atherosclerotic etiology MI, and SCAD could be a tip of the iceberg, as in this case. Both of them are non-inflammatory, and we have to look for fibromuscular dysplasia. Fibromuscular dysplasia is a female predominant disease and can predispose to SCAD, and managements control hypertension and revascularization. And these are my references, and thank you very much.
Wow, Mohammed, that felt like I was in a podcast listening to an expert with your amazing storytelling and fantastic slides. Thank you so much. And thank you so much, everyone, for tuning in. Really excited to be a part of this, and it was a great session. Thank you, Shiva, Dr. Hans, and Mohammed for presenting, and got to learn so much from you all. Thank you. Hope you have a great day.